Are we live on YouTube?
We are just going live. Yeah, I think we must be live by now. It's preparing the.
We are live. We are live. मैं अंदर को share भी कर देता हूँ.
Using Devakant third-party software.
I have a paid account, so I think.
Paid account. Okay.
सर उसमें वो thumbnail नहीं आ रहा अभी.
I've just started this.
Are we live on YouTube?
Yes. We are just going live. Yeah.
Yes, sir.
Live by now. It's preparing the.
We are live.
I'll work on the thumbnail. That is the YouTube link that I've shared. And I'll work on the thumbnail.
Background भेजा हुआ है?
Virtual background नहीं भेज.
ठीक है. I think we should start now.
Yeah, let's start.
ठीक है. So good morning everyone. Today we have a session on practice management in COVID times. So we'll be discussing the problems that we are facing during these COVID times relating to practice management. And we have wonderful people with us today on the panel and as speakers. So we have Dr. Inderveer Mishra, Dr. Ritin Goyal, who will be moderating the session. And in the speakers, we have Dr. Devakant sir, Dr. Digvijay sir, Tushya Om Prakash from Amritsar, and Dr. Tushar from Delhi. So I'll ask Inderveer sir to kindly take this forward from here.
Yeah, good morning, all of you. Welcome all. So COVID has really brought the whole world down to its knees, and starting back the practice, it's never going to be the same again. As we all know, and we have seen the trend up till now, Corona is not following a particular pattern, and it's going to remain in the air, in the market, on the surfaces for the next 6 to 8 months, or probably more than that. So once we start our practice post lockdown, it's never going to be the similar way which we used to follow up till now. There are things which need to be changed. We have to change ourselves. This session has been designed in a particular way by Dr.
Background भेजा हुआ है?
To ensure that we get an idea, get a heads up as to how to change our practice pattern in the post lockdown period. So I think we'll start with the presentation. I would like the first speaker to go ahead and share his screen.
Right. So just starting with my presentation now. Okay. So is my are my slides visible to everybody now?
Yes.
Yes, sir.
So I'm speaking on online consultation. The early bird takes the worm. We are very familiar with this proverb, and the idea is that online systems work very fast. And if you have to be in the online business, you have to be an early adopter, because mid adopters, late adopters, and laggards will lose this race. The issue is that many people feel today that online consultation is only for the COVID times, so they don't want to put too much time into it. Well, if you think so, you are highly mistaken. The world is shifting to online consultation, and COVID is just normalizing them to the new system. The system which they were supposed to adopt in the next 5 years, as it was predicted that in the next 5 to 7 years, 80 to 90% consultations would have their first step as online, and then there would be a physical examination. Since we have COVID now, COVID is just normalizing them to the new system, which they were anyway supposed to adapt in 5 years. Can we just mute the other participants?
Yes, sir. Done.
Right. So government is promoting and easing telemedicine. They are coming out with new laws, new sets of rules to make it easier and more viable. Today, more than 90% hospitals and clinics in the US are already giving telemedicine. And it is the fastest change that we are witnessing in health sector. And post COVID, it will be a new normal. For sure, it is here to stay. Then the only issue is that what is stopping you? Why are still ophthalmologists not pursuing online consultation aggressively? What is stopping them? Some people feel that it is not viable to build up a system for online consultation. Let us go into third party apps like Practo, DocPlexus, Medu. Well, I don't believe in that, because this will anyways be a part of your system today or maybe few years down the line. So it is something like you want to grow your cataract practice and you don't want to invest in a phaco machine. Well, that doesn't make sense. So if you have to be in the system, if you have to give online consultations, online appointments, then you have to have a system of your own which you can maintain and which you can grow on. Now, the other fear is that people feel it is very expensive. That to make a system, you need manpower, you need systems in place, you need automations. Well, to start, it is almost free. Rather, it is actually free. When I started online consultation, it didn't even cost me a penny. And again, if you want to grow the system, then you can invest in advertisements, payment gateways. There's no end to it to growing the system. So today, what I'm doing is that I'm not getting into the legalities of telemedicine. We have had many seminars, many webinars discussing about the legalities, what are the ICMR guidelines, what are the AIOS guidelines. So today I'm just going to show you that how easy it is, how I do it, what are the problems I'm facing, and how I'm taking out, trying to do it smoothly as possible. Now, you want to start an online consultation system, you just need two people. One is the doctor, which is you, and one would be an assistant who would help you to smoothen out the system. Well, people sometimes say that, let's do it on Zoom, let's do it on Skype, let's do it on other third party platforms. Don't get into it. Just start on WhatsApp. WhatsApp video call is very convenient. Everybody knows how to operate WhatsApp. Everybody has WhatsApp. Everybody has been using WhatsApp for quite some time now. They are very, very comfortable. The more new softwares you give to them, the more complicated and technically tech issues come into place, and then they don't want to do it. So how I do it, first, it is very important to show the people that you are there, you are providing online consultation. In the beginning, it doesn't make sense to put advertisements, because you put advertisements, it is going to cost you. Every lead generation is going to cost you, and you are going to be in losses. If you have the funds to sustain it, you can advertise. But if you are just starting off and you want to experiment it for a while, then there's no need to advertise. Use free platforms. They are very effective these days. So this is our website. You can see here that on the top I've put eye problems, speak with an eye doctor. Anybody logging onto the website knows that we are giving online consultation. Then there's another landing page on the website. I've made it as simple as possible. The less techy it is, the better for the patient. So we are just taking basic details. And you see here that I've also highlighted below the book now button that by submitting this form, I give my consent. So this is very important. This is one of the guidelines that you should follow, that you have a consent when somebody is applying for an online consultation. Then go on Facebook, again free. A lot of people on Facebook, keep promoting your post, keep sharing your post. Put it up on YouTube. So I maintain a YouTube channel. On every video, I've put this kind of a announcement that during lockdown period we are giving online consultation, so they can just click the link and take advantage of it. Put it up on Google Post. So you can see another post here. This is on the Google Post. So Google is promoting post for online consultations, and especially if you target in the COVID post. So Google, if somebody searches for an eye doctor online or some eye appointment online, eye consultation online, Google tends to give these posts more rating compared to others. Just a second. Right. So again, you have to keep it very simple for the patients. Too much tech and you lose the patient. Patient fills the form. he gets an SMS and an email as confirmation. Once he gets SMS and email, he is satisfied. He is happy that I've gone somewhere. Now he stops looking for other options. Call center gives a call to the patient. It is very important that you have a fast response time. You keep him waiting more. He's on the website, he's surfing, he's on the internet, he'll find other options. There are many people now, especially these Practos and Meadows and Docplexes kind of people who have started giving online consultation, and the response is very fast. So call center first takes the basic details and tells about the doctor. This is the ICMR guideline that you have to follow. Call center tells the patient that not all problems can be solved by teleconsultation. In case the doctor feels that you require a physical checkup, your money would be refunded or adjusted in the consultation. You say this line, patient is very comfortable, he is ready to pay the consultation, he knows that his money is secure, his money would not be lost. So then the call center shares the payment options. So patient makes the payment. Initially, you don't need to have a payment gateway. You can just use Google Pay, Paytm. They are free platforms. You can easily use and take the payments. Once the payment is taken, notifications is received on the both side, the patient side as well, and the call center side. Then call center shares a number and time of the WhatsApp video call, and the patient calls the doctor rather than the doctor calling the patient. So when the patient calls, it is an implied consent, and call center also tells the patient to take some pictures and make video of the eye. So doctor discusses the problem and sends over the prescription. So a few of the things that I've implemented in this is that how do you make the patient feel confident? Sometimes patients feel that it is a problem relating to the eye and how much can be solved on a video call. So for that, I've made a video especially for the patients, and this video says online eye consultation, आंखों का वीडियो कैसे बनाएं. That means if you're taking a consultation for your eye, how to make a video or how to take pictures of your eye so that doctor is able to see your problem. So I've made this video, and in this video I've explained that you need to use a flashlight, you need to keep about 7 to 8 inches distance, and then how you need to maneuver the eye and take pictures. So patients make these videos, patient take pictures, they send it over to doctor. Patient is very comfortable that his problem is being taken care of very seriously. So this was a video which I made. Now again, there is no end to it. There is Google ads, YouTube ads, Facebook ads. They are third party platforms. Every patient calls you, give him an option for teleconsultation, that we are available for teleconsultation. Teleconsultation has limitations, so you need to have a physical backup in place. In case you're not able to solve the problem, you should have the availability of a physical backup where you can call up the patient. Half of the problems can be solved on teleconsultation. Patient time is saved for minor problems such as allergic conjunctivitis. Patient feels that he can just maybe try on an online consultation. If it doesn't work, then okay, go to the hospital. You can give more time to serious patients. Once the system grows, you start making things more automated, but it is very important that you don't lose the human touch. Now, some of the issues and solutions to it. So once the patient has your number, he will keep bothering you. He will keep messaging you. He will keep calling you, and he will keep bothering you again and again that एक drop डालूं, दो drop डालूं, लाल ठीक नहीं हो रही, ये नहीं हो रहा, वो नहीं हो रहा. So is there a solution to that? I'm yet to find a solution. How do you tell the patient that don't call me? Or even if you limit it that your consultation is valid for 3 days, again patient becomes fussy because it is just the starting of an online consultation and they are not used to it. Now prescription medicines are not available everywhere, so try to prescribe drops which are available pan India. While doing online consultation, I've realized that allergen drops are very readily available. So again, I don't have financial interest, but in our local area, we know that which drops are available readily. But pan India, there is initially I had an issue when I was prescribing other companies drops. They were not available. Patients were calling me again and again that ye dawai mil nahi rahi, wo dawai mil nahi rahi. So this can be one of the solutions. And if you're giving a prescription, try to write a prescription in capital so that he doesn't bother you again and again कि समझ नहीं आ रहा क्या लिखा हुआ है. Or if you're giving in print, that is better. When you're sending over a prescription, use apps like Cam Scanner so that the prescription is crisp and everything can be read comfortably. Some of the people have internet issues over video calls, so there the eye videos and pictures help you out a lot. in deciding what to give. And again, there is an issue of overlapping calls because you give patient a time and he doesn't call on time, he's late, or maybe some consultations can take longer. So then there are overlapping calls. So initially I had given a slots of 5 minutes, but now I made them 10 minutes. So this was all about online consultation and how I am doing it. Open to any questions that anybody wants to discuss.
Yeah, Rahul,
Uh,
I have a question. May I? Yeah.
yeah, please go ahead.
Are you using any apps for the assessment of visual acuity or anything like that?
No, I had a look at some YouTube videos, some people who were using these apps, but I don't know. I doubt the accuracy of these apps.
Okay.
So again, and plus again, it becomes more and more tech oriented. If you want the patient to take a vision on a screen and then send you the vision, so not doing that as of now.
Okay, so we have some limited experience with some of the apps. Maybe I'll share the names here later. So that help us in gross assessment of visual acuity. So I think we can get some idea at least.
Yeah, so can we go ahead to the next speaker, Dr. Devkant?
Sure.
Yeah. That was a nice talk, Dr. Rahil.
Yes, sir.
Adaptation and hope are the two things which are keeping humankind alive. I think we need to get adapted to this new mode of examining patients, as you correctly said. So over to you, Dr. Devkant.
Yes, just a second.
So Rahul, how do you go about the post-ops and the follow-ups? How, do you charge them? Do you allow free WhatsApp consultations? How do you go about that? Because that's a good subset of the people who can be
So
managed.
initially, what was happening was that because of the lockdown, there were a lot of post-op patients calling and wanting to talk to the doctor.
Yeah.
So what we have decided now is that we don't give any online consultation for free, be it a post-op patient, be it any other patient looking for any other solution. We don't give any online consultation for free. So that we have made a rule that if you want to come over, if you're a post-op patient, better to come over to the center. But online consultations would be chargeable. So then people don't enjoy the service.
I just one question to you. How do you make sure
There's no misrepresentation. It would be really bad if someone was to post
So, sir,
or as well in the times to come?
I'm not able to hear you. This is something. The voice is getting.
Your voice is breaking up, sir. I think Devkant will go ahead with the presentation. We'll take up the question in the discussion time.
Okay.
All right.
Thank you so much. So thank you, Rahil, for giving me this opportunity to speak on this topic. So I've tweaked my topic a little bit. It was practice post-COVID era, but I really don't know when this era is going to end. So I'll rather talk on practice in the COVID era. And I'll be focusing my talk on how you can make your patients feel safe in this period. So AIOS and other world bodies have done a tremendous job in bringing us the recent guidelines. And this segment is quite evolving. The guidelines keep evolving. So I will focus more on practical tips of how we can make our patients feel safe. So keeping a hospital safe is a different aspect, and making your patients feel safe and getting that message across that your hospital is safe is, I feel, a different aspect. So all of us have gotten this data recently that ophthalmology is amongst the hardest hit practices worldwide. And apart from that, what we have realized is that probably we are at the greatest risk as well. Partly owing to the close proximity at which we examine our patients. And there have been reports about a transmission of the virus through ocular secretions as well. So I'll be focusing on three aspects. Once, when the patient is at home, contemplating an ophthalmic visit, when the patient is in the hospital itself, and when the patient is back home, and how in all these three setups, how we can ensure the safety of our patients and getting that message across. And so this will help us in the long run when eventually the pandemic goes down and patients starts to think about coming back to hospitals. So for the first point, before coming to the hospital, we need to stress on appointments now. So in India, largely there have been, we are more accustomed to patient walking in directly into hospital setups. But now we have to, probably that might be the new normal, where most of the visits are by appointments. And we have to switch to teleconsultations. Rahil has talked in depth about this topic. While in having a teleconsultation, the teleoperator becomes a very important part of this whole exercise. So we need to screen our patients during the teleconsultation itself regarding the history. We have to inform that they have to come alone to the hospital or only with one attendant. Try and avoid elderly patients or children's visits. Remind them that they have to wear masks, and there might be extended waiting time, as we might be seeing limited patients in a given amount of time. And if there are certain reports that the patient wants us to share, so that should be done beforehand, because you should discourage patients bringing a bundle of reports in their hands to the hospital. You must tell them that there might be limitations in testing. Recently, we had a glaucoma patient and we could not perform certain tests, and the patient was quite furious and he demanded that I should have been informed before. And we should encourage online payments. So this should be informed beforehand that we might prefer online payments. So just try and ensure that. And that might be a good opportunity to offer education on the virus, the pandemic, the social distancing and everything. Now, once the patient actually lands up in the hospital, the first point of contact is usually the security guard. And at times we see that he is the least protected. So you should give your security guard adequate measurements to protect himself. It might be a point of contact for thermal screening as well, and provide a hand sanitizer to the security guard. So from the beginning itself, the patient gets the feeling that he is in the safe hands. And he can ensure things about the mask and the one attendant policy. Now you have to mandatorily establish a screening desk. The staff should be in PP as much as possible. Later in the talks, we'll discuss how financially viable that is. There should be a corona questionnaire. AIOS has given us a format for that. We can acquire that. This place can also have a thermal screening platform, and the patient should be asked about the purpose of visit, and some amount of triaging can be done at this point. So this is the questionnaire. We can download it from the AIOS website. Now, all the doors of the hospital should be kept open as much as possible. This helps in cross ventilation and prevents us from touching the door knobs as well. Now, coming to signage, your hospital from the outside and the inside should have high visibility signage, and it can depict various things about the safety during these times, the questions that we are asking in the questionnaire, and the rationale to a lot of things. The reception desk is another important area. Social distancing circles should be drawn there so that patients are at adequate distances to each other. And there should be some information regarding how the workflow is going to be, so that patient is not confused and does not wander to places where we don't want him to come. Try and minimize to the paperwork, adopt EMR systems if you haven't already done that, and inform them about a separate area for suspected cases if you have formed one of those. And of course, tell them about the online payment. So recently I read this article where they have got this COST acronym where we can triage high risk patients. And if the patient comes as positive in these patients, then it has been recommended to have a separate red room where if a patient has any urgent eye problem, we should try and tend to it, and then refer, if it requires surgery, then it should be referred to a higher center. Please. Yeah, thank you. Social distancing is of high priority in the hospitals. People have come up with very innovative ideas on how to restrict people and how to have them seated at adequate distances. And we need to declutter our workstations as well. They should be at adequate distances so that social distancing can be maintained at each place. And we should do away with investigative modalities, which we might not be doing in this period. Housekeeping is one of the most important aspects in this whole exercise, and that person should also get very good security measures. Every 2 to 3 hours, or some people are doing it hourly as well, cleaning should be done. Things like door handles, side rails should be cleaned very regularly. Similarly, chairs in the waiting area, the reception desk and all should be cleaned adequately. And at the end of the day, cleaning by fogging can be done. Now, while examining for doctors and optometrists, the staff should be adequately covered with respiratory barriers as much as possible and gloves. And staff who's examining the patients up close should use ocular protection gloves and only touch the patient using disposable cotton tip applicators. Similarly, there have been a lot of innovative ways to protect ourselves that should be adopted, and the surfaces should be cleaned before and after each examination, and chin pads should be replaced after each examination. Now, another important aspect which is less talked about is staff screening. We may be getting very few patients, but almost we are at least getting half of our staff daily. So we should screen them daily with body temperature, give them as much PP as financially viable. You should have a log where you can maintain how many times they have sanitized their hands, whether they are sanitizing themselves after each patient or not. And soon we should have them tested for COVID every 15 days. And their mobile and purses should ideally be avoided inside the hospital, but if they are coming, should be properly sanitized. Now, coming to surgery, now that is another big question. Of course, we should not postpone emergency surgeries. Nobody should lose his vision because of this pandemic. But elective surgeries is a big debate right now, and we all have to take a call on that on a personal level as well. And a consent form should be signed. And now a lot of people are getting tests done for patients before taking them up for surgery. Of course, the usual preoperative measures like assessment should be done properly. If possible, the ELISA or the PCR test, rapid antibody test should be done. And patient should also be fully protected. He is also at risk of infection, and that should be informed to the patient with mask, foot coverage, and everything apart from that. So there should be minimum people in the OT, and they should all have PPEs as much as possible again. And we should avoid general anesthesia. And if it is done, then only the anesthetist should be there and limited staff should be there inside the OT. Now, once the patient is back home, a lot of people are doing is that they are calling patients after 1 and 2 weeks to inquire about their symptoms. So if the patient has come, has developed symptoms within this period of time, so then it would be a good idea to check all of us again. Now, you should insist on follow-up visit as much as possible via teleconsultations. And if medications are to be provided, it can be done through home delivery methods as well. So all these guidelines we can access through the AIOS website or ICO website. You can go and there are guidelines from all the world ophthalmic bodies. We can access it there. Now, coming to all this PPEs and all the protection, I don't know how much financially viable this is. Probably Tushar will cover it in his talk, but we should do as much as possible to protect ourselves, our patients, and our families. Thank you so much, and yeah.
Thank you,
Doctor,
Dr.
thank you, Dr. Devakant. That was a wonderful presentation, really elaborately described by you. Uh, both the presentations up till now have been really fantastic. I mean, Rahil is one of the foremost authorities. He is one of the first Indians to win the prestigious practice management competition ESCRS, and of course, everybody knows Devkant. He is the frontline mentor for most of the youngsters in India. I think we'll take up the questions in the end, and we'll proceed over to the next speaker, Dr. Digvijay sir. Dr. Digvijay Singh. He is currently a pediatric neuro-ophthalmologist practicing in Delhi in Noble Eye Care. He is also the head of department for two ophthalmology departments in multi-speciality hospitals. So over to you, Digvijay sir. Digvijay, I think you need to unmute yourself. Okay, wait. Yeah, you have been unmuted.
Am I audible now?
Yes, yes, you are.
Okay.
Please go ahead.
So I think we'll now move on to probably something which is very important for all of us in practices is how to market your practice, and particularly post-COVID. And I think like Devakan said, during the COVID period as well, we don't know when it's going to go away. I have my own private practice in Gurgaon, and I'm also looking after the department at two corporate hospitals. So, based on that, I put some points together. That marketing is rather important. So what is marketing? Essentially, marketing is making a connect with the right person at the right time with your right audience, or your target audience. So the classical strategies people have been using in marketing have been above the line marketing, which is basically for a mass marketing, little more expensive to do, lower return on investments. These are things like televisions, newspapers, radio, cinemas. And then there has been below the line marketing, which is basically marketing more specific, more individualized, more to smaller communities. And in ophthalmology, for example, camps, corporate campaigns have been used, pamphlets have been used, and in-house marketing as well comes under this. And of late, the concept is shifted to through the line marketing, which is essentially referring to a combination of both of these in a way, but predominantly in today's date is the digital marketing or the social media marketing or the what is now known as the 360-degree marketing. So this is a brief on what marketing is all about, and then let's now come specifically to ophthalmology. In the pre-COVID era, the marketing used to basically be done for brand building, which is the first and foremost aim of any marketing activity. It was to advertise services, and particularly we used to push our high volume procedures. So the ones that whenever we wanted to do an above the line marketing or we wanted to do a mass marketing, we would always push it for the high volume procedures. You don't want to do that for low volume procedures. And the focused marketing used to be for premium procedures. So if you look at this advertisement from one ophthalmology center, I've removed the name for it to be anonymous. It is, marketing a robotic surgery. And these were in the form of social media, digital media, pamphlets that they distributed, including a newspaper advertisement. And this was something that, we would saw quite often earlier. But this is going to change now. Yes.
So your slides are not moving, I think.
Okay, no, is it visible now, pre-COVID marketing?
No, only your first.
So, yeah, we can only see your title slide.
Title slide.
I wonder why. Just wait. Let me share the screen again and see. Just hold on. Is my screen still visible or nothing's visible right now?
You're not screen sharing right now.
Screen sharing is not happening.
It's not happening. Okay, just wait.
So while Digvijay sets it up, I'll just go around to the panelists and find out how many people are actually doing OPDs physically as well as online. Rahil?
Yeah.
Yeah, so it's moving. So we can go
It's
back to
moving
Digvijay.
now.
Yeah?
Yes, sir.
Yeah,
I think I
perfect.
just covered this briefly. So above the line,
Yeah.
below the line, and through the line marketing. And pre-COVID era, I was talking about this pamphlet that we have here, or an advertisement by a center, which was looking at robotic marketing as robotic surgery, as the focus of marketing. So this is what used to happen in the time before. And our entire focus was on premium procedures, something which is going to change now in the future. So if the slides are moving now, I'll move on to the next slide. Now, in the post-COVID marketing, the first and foremost purpose now would shift from brand building to brand endurance. Now it is to continue people saying that we still exist, we are strong, we are there for you. So brand endurance is going to be there. And then it's going to start shifting marketing your protocols and safety measures that you're following. And this is more evident for the COVID era as of now, and even in the post-COVID era. So you can look at a few examples. Look at this, in the picture below, on the below left, you can see how McDonald's and Audi and Volkswagen have created, different ads to show social distancing, that they have to, follow that up. And it's a way of both sending a message to the public as well as marketing themselves. In the top right, you can look at this message that was sent out by the UN to all its employees saying that, we are open for business. It was a powerful message, just somebody using a sanitizer. And we also need to now market affordability, and we need to market different strategies or a change, in terms of our focus. So if you look at this on the bottom right, and these are obviously non-ophthalmology examples, but somebody who's now marketing a online education portal, and they're marketing it as saying it's free. So, we have to become affordable, because there will be a change in consumer behavior. They'll want something things which are more frugal, which are more affordable. So this is visible to everybody, I hope. Uh, so the next slide is to understand why is it that we need to change our strategies for marketing. And the reason for that is that there will be a change in consumer focus. Ophthalmology being a very elective oriented branch, a lot of consumers may want to push back decisions in ophthalmology, decisions in surgery, particularly things like refractive surgery. And there would be a change in behavior overall. They may not want to come to hospitals anymore or clinics anymore. They may want to avoid some of those things. Practice patterns will change. They might start preferring teleophthalmology. So there is a need for you to market your teleophthalmology more over time. And of course, there are budget constraints that are going to come in for everybody. The revenues are going to dip, and it's going to take time. There will be a new normal. And so keeping that in view, we can no longer spend that much money on our marketing strategies, particularly for the newer practices which are out there for all of us young ophthalmologists. And as Dr. Rahil had also mentioned, this is the time to take the lead. So you have to be early. You have to be ahead of the others. So you need to plan accordingly. The strategy changes. So above the line marketing, cinemas, malls would no longer be the places to market yourself. People would not be going there. For below the line marketing, we know that there will be a change in camps, corporate campaigns. Corporates may not allow you to come to their places. We often do this in Delhi NCR. Camps will have to change. Community-based camps will require modification. There would be social distancing that will come in. It is not like camps will disappear forever, but the way they will be done will be very different. The way they will be marketed will be very different. And now we need to focus more on through the line marketing, which is essentially your digital marketing. And this is going to have a huge role now in the future. It already does. And this is only going to grow further. And the reason for that is it is a relatively more cost-effective technique. In fact, much of it is free if you want to look at it. And we also know that this is where actually you can get customer verification or a consumer verification, because over digital media, in terms they put their reviews, and if they're saying that I went to this clinic and I felt safe, and that's going to make a big difference for other people to come there. Or if somebody says I went to this clinic and they had said they'd do social distancing, but it was overcrowded, and they others would then kind of immediately back away. So also remember that you have to have substance behind what you market. You can't just market something and not follow that. So let's look at a few examples of the kinds of things that marketing would see. So first should be COVID safe practices. So we would all need to show our concern for the public, show our concern for people's safety. We will have to demonstrate the protocols and the precautions that we are taking. So in the form of videos from your clinic, in the form of some pictures that you could put up in your clinic websites. You need to, win the patient's confidence, as Dr. Vikant had said, make them feel safe. That is a very important thing. So that is the first and foremost form of marketing, and reviews again will come in, in handy here. Teleophthalmology needs to be marketed. You need to tell people that this is an option that is available with you. You need to tell them that this is an safe option. It's a very safe option. You need to show them how easy it is to use, and you need to also kind of tell them that this is at a lower fee. So it also shifts a lot of patients to teleophthalmology, and it does enhance your overall presence, because if teleophthalmology, you could be getting patients from anywhere. It doesn't really have to be in your immediate neighborhood. In-clinic marketing is also going to take up importance. Once a patient does come to your clinic, and you of course have to market some of the safety measures there also, but you need to market your other services. So if he's coming in, ideally he should be able to use your optical service, your pharmacy service. He should be able to use anything else that you've got to offer. And also, I think one of the things we need to start focusing on is home delivery, and that message needs to go even in the clinic itself, that if you have something else that you need, we could deliver it for you home. For example, he may order his medicines and go home, and then you deliver them. So in-clinic marketing is also important, because now he has reached your place. You need to make him utilize it to its fullest. Direct marketing is another thing that is going to, it is a form of below the line marketing, but it is going to come in handy now. This is the time to reach for your patients, to reach out to your patients through mailers, through SMSs, check for their health, check on them overall, follow up with them, remind them about their follow-ups, tell them that your clinic is up and running and it is safe to come to, and you can share the safety measures that you're following. So it is again a need for you to now create that connect. So while these are all different strategies, I'm not giving specific examples. That is for the your people who are helping you with the marketing or the creative ones to decide. But we know one thing for sure, that in the post-COVID era, marketing is going to have a role more than ever before for us to all come out of this stronger. And thank you.
Thanks, Digvijay. Excellent presentation. I think that was a really comprehensive way of covering uh, all of the aspects of different aspects of marketing that are there right now.
Right, right.
After this, I'd like to invite Dr. Tushya Om Prakash for his presentation. He'll be talking about this really important topic on salaries of staff as well as doctors. Do we actually save ourselves or do we save our employees? I think this is a question that we are all grappling with, and there are really no good answers. Just a brief introduction. Dr. Tushya Om Prakash, he is a consultant in cataract and refractive surgery at Dr. Om Prakash group of eye hospitals in Amritsar. He's an excellent human being and a very high volume surgeon, and they're taking care of a lot of staff and doctors. So I think he's the right person for this job. Yeah. Over to you, Tushya.
Thank you so much for your kind words. First of all, I would like to thank Dr. Rahil for giving me this opportunity. So I'll be talking on the salaries to staff and doctors, save them or save yourself. So I've divided this topic into three parts: legal implications, financial planning, and moral responsibility. There are a couple of questions in our mind which come when we think about this, like, are we legally bound? When is it legal to cut down the wages? When can you lay off an employee? How much can you deduct of their salaries? So I've divided this into different scenarios to make it simple. First scenario: if you can get the work done from home, you're bound to pay. Coming to the scenario two, if you cannot get the work done from home, I divided into two parts, two cases. First case, when the employee wage is less than 10,000 per month, you're not bound to pay only if you can prove your business is incurring losses. Otherwise, it is illegal. The Employee PF Provident Fund Scheme Act 1952 also comes into action, which tells us that we can allow the employee to take its 3 months salary from the Provident Fund or 75% of the credit from the EPF fund, whichever is less. Coming to the case two, when the employee wage is more than 10,000 per month, there is no legislation. It solely depends upon the employer-employee contract agreement terms. So I would like to introduce two new terms to you, which you might not have heard before. First is the force majeure. It is a term used in situations where we can't live up to the terms of employer-employees contract agreement because of causes beyond our control. The second term is doctrine of frustration. This is a certain set of circumstances in which both parties, physically and commercially, are not at fault, making it substantially impossible to keep up with the terms of the contract. So when the force majeure term is present in the employer-employee agreement contract, the employer is not bound, is not obligated to pay the employees. But when the force majeure term is not present in the contract, doctrine of frustration comes into act, where this contract agreement becomes unlawful. So there's always a question: whom can you lay off? Under the Industrial Disputes Act 1947, Section 25C, anyone who has completed not less than 1 year under an employer can be laid off, whether continuously or intermittently. However, certain conditions are to be kept in mind. Condition 1: when the employee is laid off in a pandemic of not more than 45 days, a compensation of 50% of the total basic wage, excluding weekly holidays, is given. Condition 2: when the employee is laid off in a pandemic of more than 45 days, 50% compensation is given, but no further compensation shall be payable, provided there is an agreement between the employee and the employer. Recently, the Ministry of Home Affairs, under the Disaster Management Act 2005, on March 29, 2020, has directed that all employers make payment of wages to their workers without any deductions for the duration that their establishment were under closure. Being an order passed under the DMA, this is a binding order and not a directive, but the DMA provides for criminal action against those who refuse to comply. So basically, it is very unclear that whether we have to follow. And because the thing is, like right now, with the new act coming up right on March 29th, we are not clear whether how the courts will address to this issue. So I would suggest we should not lay off any employee and wait for a strict rule coming out so that we can follow that. Coming to the financial planning, how do we save ourselves? First of all, we should assess our financial deficit. How do we do that? Study in detail about our previous 2 years' turnover with monthly revenues. Secondly, sit with your finance team and your chartered accountant, do a proper assessment and projection of the financial deficit in the next 2 quarters, and bring out a good recovery plan. So if you come to know that you are incurring losses, then only you should pay cuts for your employees, downsize the staff, and do no appraisals for them. Is there a need to press the panic button? Have you lost your patients? No, definitely not. You haven't lost them. It's just that due to the present condition where the whole system, the whole country is at pause, we are not able to deliver our products. So basically, your patients will remain yours. They will definitely come back to you. So how do we bounce back when the lockdown is over? As we all know that the revenue that would come out of the OT services, operation theater services, would take time to pick up. So we should all focus on how to increase our footfall in the OPD. First is to increase the OPD timings. That like normally, if you are working for 8 hours, you can open it for 12 hours. You can open up your evening OPDs, because if you increase your footfall, your pharmacy, your optical sales will also go up. So it will increase your revenue. You can have your Sundays, working Sundays. You can increase your outreach activities, website promotions, digital marketing, social media campaigning. So these all would help. What else can we do? We can strengthen our academic courses. There are some institutes which have academic courses running, right? Like the bachelor's in optometry, master's in optometry, or fellowship programs. So we can always focus on them because they will also add revenue. So because education will always be continued through internet portals, we should reduce our operational expenditure by double checking whatever we are buying. Everything should be under control. We should negotiate vendors for better rates. So we can negotiate with our present vendors also for better rates, which will add revenue. No new purchase or infrastructure development should be there. There should be effective fund planning, which should be planned with your finance team. Reorganize vendor and management and supply chain. Always try to minimize your stock, which is unwanted, and always do end-to-end supply chain management. You can talk to your banks, all the creditors about the payment deferments, loan rescheduling, about reducing interest rates, and revising credit terms. So, what is our moral responsibility? Our being an essential service, we doctors and everybody are obligated to work and must do their best to serve the nation in these times. We must not forget that the success of any company is based on the united efforts of its team. We are because they are. Be truthful and not show fake data of the losses and not achieving break even, because truth ultimately prevails. If your company has a parallel vertical for income, the employees should be paid on humanitarian grounds, keeping in mind that we may be the only source for their daily bread. We are very fortunate. We at Dr. Om Prakash Eye Institute are very fortunate for having a team of doctors who have volunteered to contribute for the ultra vulnerable group who have been worst hit by the pandemic. We are ensuring, we as an institute are ensuring that 100% of the wage is being paid to the ones earning under 15,000. For those having salary above 15,000, we are deducting around 25 to 50% of their salary only after understanding their family's financial status and background. Since people above the age of 60 fall under the high risk category, we are making every possible effort to prevent such employees from leaving their houses. The take home points are: Always support the workmen on humanitarian grounds. Reduce the wages if employer is just able to break even or incurring losses. Suspension of salaries to be done only if there is permanent closure of work. Be optimistic during this testing time. Plan effectively. If we fail to plan, we are planned to fail. Budgeting should be done across all levels. Delay committing major expenditure, focus on better cash flow management, freezing of any new recruitments, chase all outstanding dues, explore all growth possibilities, seal all the revenue drainage points, and at last, if the plan doesn't work, change the plan but never the goal. Thank you.
Fantastic, Pushya. Lovely talk. I think you really comprehensively covered all that we need to know regarding paying out salaries, as well as thank you for sharing with us exactly what you're doing with your huge infrastructure. I'm sure it's a big pain for each one of us to try and figure out how do I pay salaries and will I be able to afford it. But just by you putting it out, it's a ray of hope for us. You know, if and I think the measures that you put out are very, very fair, and the key goal right now would probably be survival rather than ensuring rights and responsibilities for what your staff, what your doctors should get. For the most part, what I've realized is that our staff is understanding and they realize that there is no revenue getting generated. uh, if you're fair to them, they will be fair to you, and you'll have a much more solid team coming in.
Definitely.
I think we'll take the questions at the end. It gives me immense pleasure to introduce Dr. Tushar Grover for the next talk. He's a very close friend of mine and very, very bright young mind doing cornea, cataract, and refractive surgery uh, at his own center, Vision Eye Center. Uh, it's actually a group of hospitals in Delhi. He's also a consultant at Sir Gangaram Hospital in Delhi. And he'll be talking to us about PPEs, their cost, cost effectiveness, and what to do. Over to you, Tushar. Tushar, you'll have to unmute yourself.
Okay, Tushar,
Okay,
please
hope
go
I'm
ahead.
audible now.
Okay. Yeah, great.
Thank you, Rahil, for having me. And some of the speakers have covered some of the topics very well. So I'll be adding a little bit to that. And so basically, I'll be talking about how we can go about with our finances in these times where we are hit so badly. So pretty much all industries have been affected quite adversely with the COVID crisis, healthcare being one of them, and ophthalmology, as was already spoken, is one of the worst affected because we derive most of our revenue from elective surgeries, which have almost reached zero right now. So the question over which trillions of dollars in the world economy are riding right now is how long is this going to last? And because that is going to decide how we go about it and how we stay afloat financially. So one thing that is very clear with all the projections that have come about now is that the financial implications of this are going to last a lot longer than the virus in itself. And we are most likely headed for a global recession. And India is no exception to that. India is going to be hit quite badly as well. And the economy might not be recovering till at least about 2022. In addition to that, the way we go about our work, the way we are going to do our work is going to change immensely. We are going to have to bring in social distancing measures. Along with that, we are going to need protective kits. So there is a lot of expenses going there. And social distancing means that we are not going to have the same OPD numbers, the same OT numbers that we used to. So revenues are going to go down and our expenses are going to increase quite immensely. So I'll talk about the immediate measures that we need to be taking first. So one of the important things is that you need to reconsider your revenue projections and you need to look at it from three different scenarios. One would be the best case scenario, the other, the worst case scenario, and the third would be, which is also the most likely, is somewhere in between those two. So these were the estimates that we had made initially, that in the second quarter, we would be getting about 40% of the revenue that we usually get. And hopefully by about the fourth quarter, we should be getting close to normalcy. But none of that is certain right now. And there are speculations of a possible spike of cases happening in winters, and we really don't know for sure how the virus is going to behave. So really, all of that is quite volatile, which is why we need to prepare for all kinds of scenarios. It's important to know your working capital. So, as Tushya also said, sit with your accountants, look at your financial statements, and see what your working capital is, which is basically your current assets minus your short-term liabilities, because this is what determines your short-term financial health. This is what determines if you'll be able to pay your expenses in this particular time and tide over this crisis in the next couple of quarters, which is absolutely critical. So this is something that is absolutely essential and needs to be done. And right now, cash is critical. So organizations must also quantify that the cash they have at hand, because that is when you can take the decisions, like how salaries was spoken about. Any receivables that you have pending should be looked at and expedited as much as possible. And at this particular point in time, if there is any revenue, any expense that is not bringing you revenue, that has to be considered as non-essential and has to be gotten rid of to the extent possible. Also, the inventory that you have, the IOLs that you would need, is not going to be the same as it was in the pre-COVID area. So again, that needs to be looked at, and you need to reduce that inventory because that again brings in cash into your hand. And in my opinion, marketing expenses is something that has to take a backseat right now and has to be either eliminated right now and or strongly reconsidered. Again, HR costs is something that Tushya has covered extensively. Pay cuts will have to be necessary, though of course it is unfortunate. Layoffs, again, as Tushya has covered, to the extent possible, we have to avoid it, particularly in the short run. And additionally, what we would need to do later on is maybe change in pay structures. So particularly for consultants who usually earn the highest amount of salary, there could be a transition from a fixed salary structure to either a variable or a fixed plus variable kind of a structure that you would need to adopt, because you don't know how much your revenue and your cash inflow is going to be. About rentals and about CMC of machines, this has been covered quite extensively and really well by AIOS and is also now in IJO. So as far as rentals are concerned, it's really good to maintain those relations with your landlord, because you will have to be working there for a while. So as much as possible, it should be done quarterly, but if not, then force majeure or doctrine of frustration can be used. And as far as the CMC of machines is concerned, AIOS has given sample request letters that we can send out requesting for deferral for about 3 months at least. And most companies have honored that so far. Should you be taking the moratorium that banks have given on EMI payments? We all know that that has been given. But the issue is that that interest is going to be accruing over a period of time. And you will end up, if you don't pay right now, you will end up paying additional payments, or you will end up paying greater EMI, or both. So only if you have a severe cash crunch and you have severe cash flow issues, that is when you should be avoiding those payments. Otherwise, I would say, please go ahead with those payments. In addition to that, of course, as has been pointed out again, do maintain that commitment to patients. I think we have been shut for a while now, but it's important that I think we have emergency services open right now. The panelists might disagree with me, and that's completely fair because it's a personal decision as well. And I think post-operative patients should also be allowed to visit right now, because that little bit burning irritation in that 1 week, 1 month post-op patient can also add a lot of anxiety and stress to them. So that is also important to consider. In addition to that, have somebody in your center, even if you don't give out your own numbers to patients, have someone that they can speak to and send communications to them, whether it is through bulk SMSs or through social media, and assure them that you are there and you've not gone anywhere and it's just a temporary phase and you'll be back soon. So the intermediate and long-term measures will also be very important, because we'll reach a stage where we'll start working, but our revenue is never going to be, not never, but at least for a couple of quarters, not going to be the same as it used to be. So it's important to rethink our business models a little bit. We need to get smarter as people who run practices, and we need to collaborate more between us so that we ensure profitability for all of us. All of us are becoming quite capital intensive, and we really need to rethink our business strategies going ahead. We should be able to share expensive equipment. I mean, everybody doesn't need a femtocataract smile or a femtoLASIK. We need to be sharing that to ensure profitability for all of us. And as Tushya pointed out again, no capital investments for at least the next 6 months. And in future, also, I think we should be thinking twice before we make these kinds of investments, because We need to see, first of all, if they're adding a lot of value to our patients, and second of all, if we are relatively sure of the return of investment there. And we know, as I pointed out, that there is going to be reduced economic growth. Consumer spending is going to go down quite immensely, and the most affected are going to be the premium procedures like premium IOLs, refractive surgeries, and femtocataracts. Also, we need to restructure our sources of revenue. So teleconsultations might not be adding as much revenue to us at this particular point in time, but once we start adopting them, the companies will also realize that, what we need, and they'll give us the technological backup and the technological innovations that we need. We need to increase our efficiency, increase automations of tasks, improve our processes so that we can reduce manpower eventually. This is, of course, not now, but over the long term, so that that can also cut down costs. And I think marketing costs as such, if our revenues are going to drop, also should be cut down. I don't think we should be increasing our marketing costs as has been happening over the last few years. So, and it should more, the focus should more be on patient satisfaction and increasing that word of mouth, and you can focus on in-house marketing. Also, we know that we all have a lot of these government panels or other panels that are extremely slow in clearing our dues. So I think that also needs to be looked at, and if some of these panels are too slow, our empanelment with them should also be reconsidered. Should we be increasing our charges to patients? Well, in the short term, I definitely don't think that it's possible, because first of all, on a moral ground, because patients also might not be having the affordability that you would need to increase prices. In addition to that, if the demand is low, it doesn't make business sense also for you to be increasing your prices. But I think in the long term, if we are going to have to bear with additional costs, it will have to be passed on to the consumer eventually, and we will have to increase our costs. But I think it's important that we don't degrade ourselves by giving promotions, discounts, etc., because I think that makes us look a little needy, and I think that is not something that we want long term for our profession. So I think together, we, with a positive mindset, we will get over it. Most of our previous generations have been through some crisis or the other in their lives. Some have seen recession, some have seen wars, some have seen the partition. So I think this generation will rise above it too, and we'll be stronger and smarter when we get out of it. So thank you.
That was a wonderful talk, Dr. Tushar. You have summarized it quite nicely. And as you correctly said, every generation has its own sets of hardships. It
Yeah.
grows through it, learns through it, and emerges even stronger. Dr. Rahil, can I ask you to just summarize what all the other speakers have said up till now, and give us a small brief idea?
Right. I think we have covered the topics extensively. But to summarize, we need to understand that now, post COVID and during COVID, things are going to change. And it is better that we adopt with time, because if you don't adopt now, then later on it will become more and more difficult, because today or tomorrow things are going to change and everybody has to adapt and accept it. So we've extensively covered telemarketing. We have understood that it is very important for the patients to feel comfortable and secure when they're coming to your hospital. So you have to organize your setup in a way that when they enter, they feel safe. They feel that, I can get my treatment there and not get COVID infected. Everybody is taking proper precautions. Marketing has to be changed. Heavy investment marketings and expensive marketing protocols have to be changed, and we need to shift to other platforms to give the exposure. And of course, finances have to be managed properly. Salary reductions would be there. We have to accept it. That is a reality. And everybody has to cooperate, and everybody has to understand that things are changing fast and things are changing because of COVID. So I think we have some questions here now.
Dr. Ritin, can you take up the questions, please?
All right. Before I start, thanks, Tushar. Excellent talk. Always a pleasure listening to you and just a fresh point of view. So first, I think the first question is to Rahil. Rahil, since you're taking up a lot of online consultations, what are you doing for patients that require refraction as well as glasses? Are we able to deal with those patients or not?
No, there is. I don't think that we have a way to accurately assess the refraction at this time. There are some apps. I haven't used any apps. Probably I was just sharing with Dr. Devakant sir yesterday that how he's using those apps and how effective are they. But as of now, I don't think we have a way to accurately assess the visual acuity. So anybody
So
who has
the,
such complaints, better to call them to your center or maybe refer to maybe hospital in their maybe nearby or whatever. But visual acuity assessing overline online consultation not possible.
so Devakant, I think you have some experience with this. Can you share? What do you think? How far are we? Is it, how reliable is it? Does it give you some idea?
So I've just some time back I've shared the link of the app that I've been using. So for a couple of patients which required some visual assessment because the patient recently complained of sudden diminution of vision. So I measured, asked the daughter of the patient to download this app and get it the visual acuity recorded. And then I ultimately had the patient had some vision loss. It was around 636 in both the eyes. So I had to call the patient in the clinic, and that patient actually had 6 by 36 vision. So though it's a very small sample, just one, but still, so it was it matched well. So I think it'll give you at least a rough idea, if nothing else. You'll at times patient think that there is a vision loss, but it might be something else, maybe just a dry eye, which is causing some blurring in vision. So I've shared the details of that app on the chat box. Maybe others can check that out as well.
Thanks, Dr. Devakant. Just one question, Rahil, I had for you.
Mm-hmm.
Since you're talking about online marketing as well as online consultations, and you know that this is a very open source platform,
Mm-hmm.
how do we protect ourselves as ophthalmologists from getting misrepresented? It could be very easy for someone to come up with a rahilchaudhary.com right now and could give online consultations in your name, and they could be doing anything, and you could have to face legal consequences. How do
So
you manage this or protect yourself from
I don't
this?
know. I haven't really thought that something like that can happen, but yes, there's a possibility. So that is why I think video consultation, when you are face to face with the patient, that makes you safe. That patient can see you. You can see who you're talking to. And also, when I'm doing a video consultation, I'm taking a screenshot of that consultation so that I
Okay.
have it with me as record. And also, when the call center is taking up appointments for a video consultation, they are taking up patient details, they are sharing doctor's details. You have some details from where the payment is coming, and all those things make you give you some kind of security that who you are talking to, and misrepresentations and maybe something like that cannot take place. But yes, again, online there can be a risk of all of this, and that risk has to be taken if you have to give online consultations. So that is very
Understand that. Understandable. Very fair. Rahil, can you also explain the charges for online consultation? Should we be pricing ourselves similar to our regular consults? Should it be lower or should it be higher, since we're dealing with a lot of financial stress? How are
yes.
you dealing with this?
Some hospitals and doctors are charging what they charge otherwise when some patient comes to the hospital. But initially, I started off as free. So for 1 week, I was giving free consultations, adapting to the system, understanding how it would work, adapting to the shortcomings. And then to start with the payment things, I started off with 100 rupees per consultation, not to put too much burden on the patient. And also patient feels comfortable ki in case my query is not resolved, in case my problem is not resolved, then I don't lose a lot of money. But then initially it started becoming popular, and there were a lot of patients coming up. So then gradually I increased it to 300, then 500. So right now I'm charging 500 per consultation, getting decent amount of about 20-25 consultations in a day. So that is
Wow,
working
that's very good.
nice and well.
That's very good.
I have a comment there. May I? Yeah.
Yeah,
Yeah,
please
please,
do.
please.
Regarding the like the legal aspect of things, so what I do is our teleconsultations are moderated through the call center. So once an appointment is booked, the patient is sent a similar app where his visual acuity is recorded, and the EMR is also involved in this. So the operator fills up the basic data on the EMR and then sends it to us. And then the calls are taken over on Zoom. And when they are taken on Zoom, I always record my teleconsultations, and I insist on the video mode as well. So record I maintain a personal record for those teleconsultations, and so I think that can be done.
I think that's a very good idea.
Great. I think there's a question from Karan.
Hi everybody,
Hi, Karan.
webinar. So I have one question over here. So there was, according to the AIOS telemedicine guidelines, they had mentioned regarding consent. So they had mentioned about implied consent and explicit consent. So for explicit consent, implied consent, they had said if the patient initiates the conversation, it is understood that the patient has, given you consent. But in the other way, what they have recommended, either a voice recording or some sort of written format or a video recording saying that I want consultation with this doctor. So, yeah.
Exactly. So we are working on both the consents. So the form that we have placed on the website, it mentions very clearly that if you're filling the form, you're giving consent for the online consultation. And again, we try that patient calls the doctor. So we share a number with him, give him an appointment time, and the patient is calling the doctor rather than doctor calling the patient. So again, both kind of consents are being taken care of. And again, when somebody is calling on the call center, so again, the whole conversation is being recorded. So that way also you have a record that patient reached out to you for whatever problems or online consultations you wanted.
I have one more question, if the panel would allow me.
Please go ahead.
Like, see, you guys are right now in an urban area, so most of you are in Delhi right now. So the patient cadre that you get over there is very different from in the rural areas. So, like, I have also been trying to develop a teleconsultation system over here. So it's been a little bit of a problematic situation because the patients are, so suppose about it, the teleconsultation acceptance right now is less than 5%. And even though when we are charging only rupees 50 for teleconsultation. So any recommendations or any, things that you would suggest to go about this? Tushar has worked in the scenario, so Tushar will have an idea.
I'll try and talk a little bit about that. I think in rural areas, what is more relevant would be to have vision centers. So just small centers and MLOPs, trained MLOPs taking care. Because if you have these small vision centers in areas which have a low cataract surgical rate, have a low exposure otherwise to eye care, that's where you would need to set up these small, tiny vision centers, and they act as a source of teleconsultation. Because otherwise, to get them to use WhatsApps and apps is a little complicated, and it's not going to work, I think, in our rural areas. So that is where vision centers, I think, really help, because they also help you bring referrals of surgeries, can also bring in paying patients. So that, I think, really helps in rural areas.
I think this is also where the marketing of teleophthalmology will come in. So this is the time where you need to kind of probably send a message to all the patient database that you have, saying that you're available for teleconsultations, because I think everybody has a mobile phone these days, whether it's in your urban area. So this is where the role of that marketing will come in, in terms of marketing your teleophthalmology services. Otherwise, people will not know, and it doesn't have to be through video.
And initially, your first patients for teleconsultation would be your own patients, whose data you have, whom you are able to reach, send out messages and emails. They would be the first patients calling you that, we have been coming to your center, now we are having this problem and we are reaching you for our solutions. So they would be your first patient, and initially it would gradually become popular and you would start getting more patients. Also, I was discussing with somebody, one of the other approaches to telemedicine is that somebody was telling me that you don't charge a high fees upfront, like don't charge 500 rupees, but start charging maybe 50 rupees for every call they make to you. So maybe if the patient is under your treatment and he's calling you 3-4 times and choti problems ke liye, so you can charge him for every call that you take of that patient, maybe a less amount, but that would gradually add up.
Yeah, but I think that will also be dictated by how much time we actually have once practice resumes. Because right now we are very free, but we might not be able to do that kind of work once we start our routine practice.
Yeah, so once it becomes a system, then obviously you need to dedicate somebody who would be there taking online consultations. Like we have people taking care of chats, taking care of phone calls. So you would have somebody taking care of online consultations as well.
Yeah. Great. Indivar, would you like to add something or any questions that you?
One question was directed towards Dr. Rahil by one Dr. Swati. If the patient doesn't respond to the online treatment you are given in the first go, what do you do after that?
Well, if he doesn't respond, call them to the center. Or if he's not in your city, then maybe ask them to visit an ophthalmologist nearby.
Okay.
And maybe have a word with the ophthalmologist, just to let them know about their medical records and other things.
if you've given a treatment, whatever you felt was best, and it didn't work, no point changing the treatment and continuing it further.
Shooting in the dark, there's no point. Tushar, one question for you I'd like to ask. Tushar, these projections of what the decline is going to be in our practice coming quarter on quarter, and I'd also like to get Tushar's opinion on this. What do you think is in play here? Like, next 3 months, you're saying maybe 40% and then 60% and then 80%. Is this because of the patient inflow, or is it going to be because of the things that the government is going to impose on us?
See, all of that is based on what we preliminarily know of how the virus is going to respond, how we expect the curve to flatten out, but we can't deny the fact that we don't know everything. So these are just estimates based on the fact that hopefully in about, like how we are going to start practicing, I think in about 2 to 3 weeks, despite the fact that coronavirus is not going anywhere. So our work is going to slowly increase, and that is what the estimate is, that by about 3 quarters we should be in control of the situation, and we should be able to an extent resume activity as normal. But
Hopefully.
as I said, we are not be sure, and if there is spike happening, then it might vary.
Tushar, do you think we'll be able to ride over the next 3 quarters this way?
So basically, it is very difficult to say right now. So what I had mentioned in my presentation was like lockdown, how we can start our services. So we can basically follow all the measures and start the OPD after the lockdown, slowly increasing the working hours, dividing the staff. If you have a good number of people with you, you can just divide them on different days, give them a week off, then call them again, so that everybody has a good time, good quarantine time also, and just make sure that your work is carried on safely with all the measures, and you can continue for like during this time, because this time, this COVID-19 time will definitely prolong for 3 to 6 more months. So slowly or gradually, everybody has to open. So why not we just follow all the guidelines and open it as soon as possible after the lockdown?
I agree. Karan, I think he has a question.
Yeah, he has some questions.
One question I have, and this is to all of you, the panel who are doing teleconsultation right now, is when you've already consulted a person for teleconsultation, suppose you've charged an X amount. So and when you see that the teleconsultation was not enough, he needs to, or he or she needs to come to the hospital. Are you charging extra for that charge? Are you the normal charge? Are you giving a discount when they come for a physical consultation?
So what we are doing is that the teleconsultation rates are 500, and if somebody's problem is not sorted, or maybe somebody requires a physical examination, then what we are telling him is that you can come over. Those 500 would be adjusted in your consultation amount. So if the amount is 1,000, then you only need to pay 500 more, and that online consultation amount would be adjusted in your consultation amount.
Which is very fair, I think.
That maybe if somebody is outside Delhi and he's taking an online consultation, and maybe he's a case which you cannot solve on a video consultation, then we refund also. If we cannot solve his problem, then it is better to refund his money. So he gets more confidence in you that they're genuine people, they're doing the right work, and then he comes back to you for another opinion at times. That's what I've realized.
So a lot of our teleconsultations are free right now. So all our follow-ups and patients which we had seen in the past 1 month before the lockdown, so for them we have done a free teleconsultation. So
that is also what we have decided, that during the lockdown we won't charge anything for teleconsultation, because that is also a marketing strategy, if you say so.
Yeah, I think we're doing something very similar as well. The way that we went out marketing ourselves to our patients was we took out a list of every patient that was operated in the last 12 months, sent them out an SMS saying that we're available on the phone, and which is easy. And we're even more available on text or WhatsApp, because that way you don't miss anyone. As long as the patient sends you a message and we have a prescribed format, the patient has a picture of his discharge summary and get back to me, and we will not charge them anything, of course. And on top of that, we are actually not taking any new patients, because that is responsibility that we right now are not sure how much we'll be able to take care of. If there's a patient who has a problem, who I have never seen, it'll be. I'm sorry, I'm getting some background. Yeah. So that is a responsibility that we've kind of left out. Indivar?
Yes, there is one more question on YouTube. One person has posted ki, even though Dr. Tushya mentioned that the deductions in the salary cannot be made, but still, even the government sectors and many of the private sectors, in specifically in Maharashtra, I can say because I'm from here, from Bombay, there have been doctors who have been having their salaries deducted. So, any comments on that?
I had actually told that deductions can be made if
Hmm.
your company is not is incurring losses or is not able to achieve break even or has just achieved break even. So deduction is in the hands of employers, because the thing is those people, employees who have wages more than 10,000, it solely depends upon the employer employee agreement. The only thing is you can't lay them off, not even to because recently what the government has come up with in March, when they had announced that you cannot lay off any employee during this time. So they have mentioned it particularly even to those employees who have not even completed 1 year.
So I agree with you,
Okay.
Tushya, but there is, some legality to this. I was part of a webinar of some lawyers recently, and they were talking about. So you have to look at it in a reverse perspective. Should you cut salaries or should you lay someone off? What is the manner that you could get prosecuted in,
Hmm.
right? What happens is, now you're talking about 10,000. I think we should call that anything under the Minimum Wages Act, because that's going to be different from state to state. In If you are cutting salaries or you are cutting pay, or you are actually laying someone off, what is going to happen is that your employee could take you to a consumer forum or to the labor department. At that time, you are going to have to justify why you had to take this step.
Exactly. So if you
You know,
justify you are incurring losses, then you are
correct.
just, so
So
you're
I
not
think
supposed to like defy your employees by telling them not the truth. So if
so.
you are truthful to your employees, they also know, they are very understanding that because we are not working, we are all incurring losses. So that time you can do it.
Your bank statements should be able to show that you have a serious liquidity problem, and you should be able to prove it retrospectively in future. And
But
you need to think about that when you're taking these decisions.
this is
Exactly.
also sub judice. I think there's a petition in the Supreme Court which is still ongoing as of now, as we speak, where a confederation of industries has gone and approached them saying that we can't afford not to cut salaries or not to do this. And I think Supreme Court is still sitting on that. And if we get a direction in some time, then that would be over the act, because the Supreme Court is trying to do that. And I think it's very soon. It's going to come in a few days.
Yeah, that's what,
And
because the
So
problem here is this has happened for the first time, this pandemic situation in India. So it is a new thing, and we don't know how the courts are gonna address this issue. So we just have to have some patience and see how this will go. And the most important thing is not to lay off any employee, and just to see and pay your employees how much ever you can, because that you are the one who are gonna help them at the end.
so
the
the
act that
position
they've
as of
taken
now,
to the
yeah,
Supreme Court has
please.
been the one which is saying that in the Disaster Management Act, it is actually the responsibility of the state and the governments to take care of the people, and to take care
Wages,
of
yeah.
their. So therefore, the petition is saying that 30% salaries the employer will give and 70% the government should give, as is happening in a lot of Western countries. Because at the end of the day, it is the government's responsibility to take care of the citizens. So that is what they have said. And if supposing the Supreme Court was to accept something like that, which is highly unlikely, in that case, we're all safe. But even if it does not, it is unlikely to say that 100% then goes to the employer. It will be something in between.
And it
I
is so
think
unfortunate that in India, the government is not supporting any of the industries or hospitals or anything.
I think we need to wait for that. I think that to be fair to the government and the courts, they are trying their level best. They have a lot on their plate, and the Supreme Court has. So the Labor Department so far has been sending out. They've been cherry picking companies like SpiceJet and others, telling them, giving them instructions that you can't lay off someone, you can't cut their pay. And the Supreme Court has actually come to our aid, saying that you first need to take out a notification, clear cut, that you can't cut pay and you can't lay off, because that notification has not come out from the center yet. So once that does come out, then the Labor Department can actually start this kind of harassment that's kind of going on by cherry picking big companies. But yeah, I think we're in uncertain times. It's going to be difficult to say what's going to happen.
Also, one more point. Actually, we have all of us are working in hospitals or running our own hospitals, and we have employed these people under us, and we have developed a kind of a personal relationship with them. It's not just about the money. I mean, if it is a good understanding you are having with the person, with the employee, I don't think there should be any trouble. But laying them off would be a huge drastic step which can have repercussions. Rather than that, you can go for a pay cut. That is what I've done with my staff. I have told them ki, see, mine is a new hospital, I cannot just pay you upfront right now. I'll be paying you somewhere 40 to 50%, and then 20-25% every month once the hospital picks up later on, probably.
The
That's
best
very
part is
fair.
you're fair to the employees, they're fair to you.
Yeah,
Yes.
correct.
I
Right.
think another simple strategy can be that if you're giving your employees a pay cut, allow your employees to take an advance. Because if you have, say, 40 or 50 employees, not everybody is in a bad shape right now. Some people have some you could have, some people have savings and they can get by, and others really need the financial help. So you could take it on a case to case basis, like how Tushya's mentioned during his talk. And people who require give them up to 1 or 2 months of advance, and they can pay that back in the next 6 months or however. Yeah,
Yeah,
I think that's
like I mentioned that in that Employee Provident Fund Act, you can
correct.
let them take their 3 month salary.
Yes.
Yeah.
True.
Yes. So I think we should start with the online consultation. Each and every one of us. See, my teacher from my DNB days, he used to say, "Ki it's we have to train the patients. Our how we see the patients, that is how the patients get trained." So once we start with the teleconference, telemedicine, this is how slowly the patients will learn that, yeah, this is also a modality of consultation which we can pick up later on. And COVID is not behaving like any other virus. The reports which I've seen, see, there are multiple reports which I was reading yesterday. They say a social distancing of 1 meter or 2 meter is enough, but they have found out that in a closed environment, even if you have kept the windows open, if a person sneezes, unfortunately, if the mask is below the nose level and he sneezes, that aerosol particles at one time can be around 5,000 in number, and they can travel to a distance of almost 4 meters. So they found out that in such environments, even on the floor, 70% of the staff who is working in that area had RNA of the virus on their footwears. So such things are going to be difficult. I mean, this proves that we don't know whether the virus was viable or not, the one which is on the floor and which is in the aerosol formation. But the practice pattern is going to change in the next couple of months, and it's going to remain like that for the next I think around 9 months to 12 months. I think telemedicine is the future for most of us, and since we are in ophthalmology, we are in the front line, we and the ENT people, I guess. Because another report says that for 21 days post COVID, the virus is found in the tears. I mean, these are just random papers which have
Anecdotal
been
reports, yeah.
considered, but these are reports which have to be considered because we don't know about this virus. We are still learning about it. So,
Devakant, can I ask you a question? This is from one of from the audience, from Sanjeevani Shinde. Thanks for your question. Can we prescribe steroids online or on teleconsults?
Right. This is something that we discussed while we were formulating this plan. So ideally, I would avoid doing that, because though we have a good picture clarity now, but still examining the cornea with probably a red eye becomes a tough task. So I think we should avoid prescribing steroids, and you should call the patients if you want to do that to the clinic.
Tushya, there's one question for you. And this is from Mr. Sunil Kumar Jain. I'd like to ask you that the pay cuts that you're doing, are you planning to pay back the balance amount
See,
over time, or what is your policy right now? And how do you advise us?
personally, if you ask me, I would love to give it back, but legally we can get away with that, because the thing is, if in a month you're not earning at all, or you're having a lot of loss in a particular month, you can have a pay cut for your employees. But we as
Dr. Om Prakash Eye Institute, we have decided it that at the end of the financial year, we will see if the things get back to normal quickly, and we have a good financial year of 2020, then we would probably give some incentives to our employees.
There's another question. Is it mandatory for employers to provide health insurance to all employees from a legal standpoint? Tushar, can you take that as well?
We have decided it to get it done because for those employees who have served us for more than 5 years, we are getting that thing done for them.
Okay, great. So legally, what happens is that if you have 10 or more employees, then you must enroll all your employees under ESI, which is a type of health insurance. But this is only applicable for employees who have salaries below 23,000, and those who are above 23,000 don't get that insurance.
Another thing, what we have done is for all employees, we have got that ESI insurance done for them.
Yes,
They can practically everybody can avail health insurance from the government hospitals. If
that's true, but that's only for employees who are below 23,000 in salaries.
Yeah,
Anyone who has a salary of about 23,000 cannot be enrolled in ESI.
Yeah.
ESI, the contribution of there is a contribution by the employer as well as by the government right now, which helps out doing this, and it's quite beneficial.
yeah.
In fact, one more thing that we're doing is that rather than just announcing to your staff and doctors that we would be doing a salary cut, we are telling them that we are looking at options, and if everything goes fine, if we are able to break even post COVID, then probably we may not cut the salaries. Then we may give full salaries if we are able to generate some profit that we can dispatch salaries comfortably without procuring any losses. So that is one more thing that can be done, that rather than just announcing that everybody would have a salary cut, it would it can sometimes makes the staff a little hostile, that if you do good business post COVID, then they try to turn hostile, that they've earned well, they've done good business, and still they're not giving us salaries.
But Rahil, don't you think this is playing with fire? Once 3 months from now,
See,
if
what
you're
happens?
not making too
Suppose
much money,
suppose the lockdown opens and you do good business, and you've already announced a salary cut, then the staff doesn't feel very good about it. They feel that
I agree.
so
I agree. It's a two-edged.
they've generated profits, still they're cutting our salaries. So there's a different approach that can be adopted, that just tell them that okay, we are looking at it, and if we do good business, if we make profits, we'll give you good salaries. So that way they're more comfortable.
But my alternative question, just playing devil's advocate here, is that should you not be making good money 3 months from now, and in trying to actually break even, in trying to do better, the money that you will be spending in advertising as well as marketing, will your staff not get hostile then? That you're not paying them, but you're spending money on other things?
Now if you start calculating it, there's so many aspects to it.
But I think it's
Right.
fair to, because right now what is being paid for March, what we are paying for reserves of the organization or the owners of the organization. I think it's fair enough if even if the organization starts making a profit, say June, July, to give them their regular salaries. And if you get a lot of surplus and your business increases because there was a lull period here, then maybe give bonus. I think it should be assured to them at this stage, or any guarantees given to them at this stage of that sort.
Yeah, I think there's a lot that we don't know, and I think we should not play with things that speculation.
This is not the time to be making decisions for long term at all. Actually, this is just immediate term decisions. You want to know what's happening in the next 2 weeks. So how many of us are going to get into elective procedures sometime in the end of the month? Again, it's a big speculation. So I'm not sure that's going to really happen. Safety is first, I suppose, and you must ensure that.
And I think it depends on regions also. I mean, it might be very difficult to do that in Delhi, but I think in places like Bangalore, people are starting to open up now, because the number of cases is not that much. But I think Delhi is going to take a lot longer.
So just taking
Mumbai
forward,
is also going to take a very long time.
very long time. Yes, Digvijay's question is I think really important, and I want to ask this of the panelists, that if we are opening up our clinics for emergency services, for OPDs, and we're taking this kind of risk, why are we not doing elective surgery? The surgical environment is the most controlled environment. it's the least likely to give infections, and it's going to run the engine that actually powers the house. So why completely move out of surgery is I just
See, if you see it in for the cataract surgeries, we were just having a discussion that, as we all know, that phacoemulsification has been producing aerosols. So we are just waiting for buying some time to just understand how it will be, and if we can plan doing less number of surgeries in a day or something like that. So if we are doing elective surgeries, we will be doing very like the numbers will be very less per day, definitely, for sure.
so that's less.
Sorry, I couldn't hear.
Will that be that those are going to be low numbers because people are not patients are not showing up, or is it because as a policy decision you're going to make sure that you're restricting your numbers?
As a policy decision.
Okay, that's good to know.
I think the reason why we wouldn't do elective surgeries as of now is also keeping the interest of the patients in mind, because if you do the elective surgery after a month, 2 months, it's not really going to matter as much. But somebody who comes with an ocular emergency cannot be sent away. So I think just keeping that interest of the patient in mind and leaving our finances aside also, I think that makes a little more sense.
That's very fair.
There have been multiple cases that have come out where the healthcare worker, the doctor, the entire team has got infected. Whether there's some cases in orthopedics have come around and some cases in dental. So the point is, when you're in a closed operating room, no matter how much care you take, you have a high viral load. In an OPD, there is a change in air, there's a change in environment that's happening. Even the current filters in the OT are not that effective. As a matter of fact, some of them are actually just increasing the amount of aerosol. So we aren't too clear on that yet. So I think it would depend on everybody's risk appetite, I feel. But at the end of the day, it is something that personally I would not want to get into, at least for some time. But again, when I say for some time, we still don't have an answer as to how much time. I don't think I can spread it
I
forever.
agree.
So
The
I
air
agree.
handling
My
unit
point of asking,
in the operation theater recirculates almost 90% of the air. And the HEPA filters, the smallest one which is normally purchased is 0.3 micron size. The virus size is even smaller than that. You want to go for even smaller than that. I mean, there is a filter which is I forgot the name. It is 0.003 microns, but that is like one filter. If you want to purchase, goes to the tune of almost 75,000 rupees.
so that is the HEPA filtration, which is the
The HEPA
standard
filtration, yeah,
0.03.
yeah, that
You're
0.03.
supposed to have that.
Yeah, so
And second
even
thing is
that
that
cannot filter the virus. That is the reason
the,
why I think most of the people are avoiding surgeries.
the
HEPA
recirculation of air
in,
is in your hands. You can decide how much you want to recirculate, whether 90% or 10%. You can wind that.
You can increase the number, the flow of air, but still there will be a recirculated air inside the operation theater. People are what they are trying to do is the risers. They are trying to put a UV light now.
exactly.
If
what
you
I
have
was
got 4 risers, you can put UV light. That will ensure around 70% disinfection, but 30% still remains to your imagination. I mean,
And coincidentally, right now, whatever OTs are built are based on the positive pressure. They try to create positive pressure inside the OT. So we can't. That's a big problem because everything will be going out. We
precisely.
need a negative pressure inside the OT. So
So
that's
idea,
How many of
you
you
can
are
actually
planning
turn
to
that.
get COVID testing done for patients who are going for elective surgeries?
No, it's
We are
very
planning to
difficult.
get it done at our center for retina cases.
a ruling has come recently from the government that asymptomatic cases should not be we shouldn't perform surgeries on even asymptomatic.
yeah,
There
they're
is,
saying it should not be mandatory to do pre-testing. As if I think
It's
just
not
come in.
mandatory, but I feel it's a double-edged sword, because suppose you do a testing and the patient comes out to be positive, and right now we are in the contact tracing, we are not into community spread. So it's a positive patient. They will try to trace back the contact. They will find that he had visited your hospital, and they seal your hospital. And and otherwise, if suppose the patient is negative and later on he becomes positive, then he's behind you, he sues you that I went to this hospital and I got positive.
And
Then
80%.
again they come back to your hospital. Oh, he's got infection from here, he visited your hospital, again they seal your hospital.
Either
So
way, you get sick.
Rahil, but what is the problem if you get sealed? You've got exposure. You opened your clinic, you got exposure, you should get sealed, right?
Hospital
Where is
staff anyways at a risk of exposure. ऐसे hospital seal हो जाएगा तो क्या
so let's close our eyes and open the lockdown, yeah?
No, that's not the
that's not
case
fair.
actually.
That's not
No,
fair.
this is something
he
like
sees a patient today and its hospital gets sealed for the next 14 days. And then he opens up on the 15th day and gets a patient again on 16th day, a positive patient. And again, 15 days hospital is locked down.
The problem is
So-
it is not easy to get your hospital opened.
That's like Ludo then.
So much that has to go behind opening your hospital.
But that is, I think that will also change. They can't keep closing hospitals. I think there was some news
No,
article.
in Maharashtra,
I think that-
there was
yeah,
a
I
ruling
think
in
so.
Maharashtra right now that even if the patient turns out to be positive, the hospital and the staff, the staff, if they don't show any symptoms, they are not. It is not mandatory to close the hospital more than 24 hours.
I
And
was reading that.
yeah, so we have that ruling right now, and we have been told by the BMC that you have to keep your hospital open at least 2 or 3 hours every day for the emergency patients. This is for the general practitioners and the other specialties, but even for the off time, a few of the doctors in Bombay have received notices, show cause notice, that why haven't you opened up? So slowly, most of the people are opening up, but I think elective surgeries is something which is still a distant dream for all of us.
In the
Uh,
news that I read was that you close your hospital for 24 hours and
Yeah.
you properly get it sanitized and then you open it back. I was also
Rotational shifts of all the staff members will help a lot.
Yeah, dividing into two teams, probably just making sure that one is
Yeah.
not exposed if one is. There's a question about disinfection of trial sets as well as 20 diopter lenses and 90D lenses. I also wanted to ask you, are you guys doing refraction in the OPD for whatever patients who are coming, or are you trying to avoid that and postpone that for right now?
We are trying to avoid.
avoid if you don't need it. So somebody is coming for a red eye, khujli pani, not required. Otherwise, initially we were doing refraction for everybody who was coming, even if it's coming for minor problems, not vision related problems. But now, first he goes to optom, he takes in history and assesses if he actually needs a refraction or not. And if he feels that refraction is not required, directly to patient. Then in refraction we postpone it.
We are also avoiding it to the extent possible and also trying to avoid NCT.
NCT, a lot of people are saying aerosol problems. So
What
now-
protocol are you following for cleaning these? The question is that trial lens and 90D lenses.
I'm using alcohol swabs. I don't know sodium hypochlorite if it can be used on lenses. I don't know how. Wouldn't it be too corrosive for lenses?
It is corrosive, trust me. Tried and tested, and I've lost one set.
Burn.
Burnt my fingers. Please, no sodium hypochlorite. In fact, even the waiting chairs, you spray it on it and clean it once or twice, nothing happens. But after a week, I started getting those spots.
Stains. Yeah.
Yeah, stains, and it's horrible. Yeah, it spoiled my furniture.
Okay, so I have two questions from the perspective of a young ophthalmologist. Now, I was talking to a couple of fellows. They have recently finished their training and they were just starting to look out for jobs. So a lot of you are amongst the panel are employers as well. So what do you have, any tips or any suggestions for them? For somebody, probably I think recruitments will not be on the cards for some time. So what do you suggest for them? Somebody who has just finished training looking for jobs, has nothing to do right now.
Join charitable hospitals.
Charitable will probably also not take
Especially because
the-
camps are off for a
cases going
while.
on.
I think be patient, wait for a while. This is all settled down. Stay updated, watch webinars. I think because right now there is
Start with online consultation.
Online. Yeah, that might
be the first step right now.
That's a good suggestion.
We have one question here that if your staff lives in containment area, are they permitted to come to work? We are not allowed, to be very frank, if they are living in containment areas. So we are avoiding calling them. And in fact, even if the patient is coming to your hospital and he has to fill a form where he's coming from, and if he's from the containment area, and if it is not an emergency, we are telling those patients to avoid coming and not enter the hospital.
And I wanted to ask, what is the consensus on PPEs? Because nobody seems to be sure. I mean, we are not using PPEs as such, though we've gotten some for our OTs and we've kept them, but we have not yet used in the OPD or even in the emergency retina cases.
I ordered 50 PPE kits, gave them to the staff. वो एक दिन पहन पाए. It is so difficult to wear them.
Yeah, that's what.
So then again, now we have shifted to caps and surgical mask and those protective goggles and a disposable gown. PP wearing PP is very difficult.
So
I think we
what we have done is
the OTs if you want to take up cases, I feel. But it's very difficult to do OT in that as well.
Yeah, that's
Very difficult.
what we have done is a surgical cap, shield, and a 3M surgical gown.
But exactly. That
true.
disposable gown jo hai.
Yeah, disposable gowns, and we have kept one ETO machine for that, and it keeps on like
ETOing na?
every day.
Initially, we were also doing that, but now what you started is that we put them in a room and then we fog the room. I don't know how effective is that, but we are
That
doing
is already done. That is also done. In addition to that, we ETO it also.
You can also put it in the pass box, the one which contains the UV light.
Also, how many times would you reuse an N95 mask, and would you ETO it or use plasma? What would you do? What is the consensus on that as well?
AIMS came out with a good data that even if you don't do anything, you just keep it on a surface for 5 days, you can reuse it twice or thrice. Well, I've used it more number of times, I'll admit.
Yeah. You also ETO'd it. I'm not sure how good an idea that is. We've been ETOing the N95 masks, but maybe not a great idea. I'm not sure how scientifically valid that is. We should be doing that.
I
I think we've had a
we
very
can
deep
wrap up.
discussion. Yeah, we've had good ideas in the session. And with this, we can wrap up. If anybody has any other questions, so they can put it up on the YouTube video or the Facebook live video. So we'll try to answer those questions here. Right. So thank you, everyone. Thank you, all the panelists and speakers, for taking out time and making this session a success. So
Thank you, Rahul.
we'll
Yeah.
wrap.
Thanks, Rahul. Thanks for taking up this.
Well,
And thanks to
thank
all the audience for being here. And
Yes, and to Olympic for managing the
thank you.
entire.
Thanks, John.
Nilambic, yeah.